Dr. Zareen Kiran is going to have detailed discussion on prolactinoma. Dr. Zareen Kiran is consultant endocrinologist and assistant professor at National Institute of Diabetes and Endocrinology. So thank you so much, ma'am, and over to you, ma'am.
Okay, thank you very much, Mr. Saad. आपने बहुत introduction अच्छा दिया मुझे. So I really like the theme of FARMEVO that they are organizing this regular topic-based session for endocrine fellows. I wish I can do further on this. And today my topic is on the topic of prolactinoma. So the agenda of today's talk would be to understand a bit about the physiology of prolactin hormone, etiology and pathology of hyperprolactinemia, evaluation and diagnosis of hyperprolactinemia and prolactinomas, then management strategies of hyperprolactinemia and prolactinoma, special scenarios related to the topic of prolactinoma, that is giant prolactinomas, and scenarios of pregnancy. So I'm going to really start from the very basic so that the whole topic of prolactin and prolactin related problem is addressed. So human prolactin gene is located in chromosome 6. Apparently, it arose from a single common ancestral gene giving rise to the relatively homologous prolactin, growth hormone, and placental lactogen related proteins. It is a 199 amino acid polypeptide containing 3 intramolecular disulfide bonds. And it circulates in blood in various sizes. So these are the 3 main varieties or main categories of prolactin hormone which circulates in blood. Number 1 is the monomeric prolactin. It is also called little prolactin, and it is small in size, and it is the one which is most bioactive. Then number 2 is the big prolactin, which is a dimeric form, and then third is the big prolactin, which has polymeric forms. So a lot of monomerics are combined in that. In response to the TRH, that is the thyroid releasing hormone, the thyroid releasing hormone, the proportion of the more active monomeric form increases. So, the pituitary dynamic testing sometimes use this type of stimulatory test to assess the prolactin availability. Now, coming to the inhibitory and stimulatory factors which affect prolactin release. First of all, I'm going to discuss the inhibitory factors. That is, the hypothalamus has inhibitory effects, which is mediated principally by the dopaminergic neuron system and the D2 receptors on the lactotrophs. The dopamine neurons, they themselves are stimulated by either acetylcholine and glutamate and are inhibited by histamine and opioid peptides. So opioids can actually inhibit dopaminergic tract and in turn can cause release of prolactin or cause hyperprolactinemia. So, coming to the stimulatory factors, you can see here all the interplay between the inhibitory and stimulatory factors. One or more of the prolactin releasing factors, that is a TRH, again the thyrotropin releasing hormone, the vasoactive intestinal peptide and oxytocin probably mediate acute release of prolactin. For example, the suckling process in breastfeeding and during stress. The neurons of these factors are activated by serotonin. Estrogen also sensitizes the pituitary to release prolactin, which feeds back on the pituitary to regulate its own secretion. So there is a ultra short loop feedback within the pituitary through which prolactin, control its own release. And also influence the gonadotropin secretion by suppressing the GnRH, the gonadotropin releasing hormone, which comes from the hypothalamus. So the short loop feedback is also mediated indirectly by the prolactin receptor regulation of hypothalamic dopamine system, dopamine synthesis, secretion, and turnover. So you see, this short loop feedback is important from the point of view how prolactin is controlling its own secretion within the pituitary gland. Now, what is the prolactin secretion? How is it we have to understand the physiological variation and its normal phenomena. The calculated production rate is 200 to 536 microgram per day per square meter of the body surface area of a particular person. Half-life is 26 to 47 minutes, which is quite short. So there is a lot of physiological variation. The prolactin secretion occurs episodically. with 4 and 14 secretory pulses over 24 hours. Highest levels are achieved during sleep and lowest occur between 10 a.m. and noon. So this is the normal physiology. Okay, we often ask our patient to go early morning for endocrine testing. The reason being that majority of the endocrine testing, endocrine hormones, the hormones, they are on the higher side during the early hours of the morning. But this prolactin is the one which is lowest between 10 a.m. and noon. So this is a bit different because it is not required in the daytime activity and the alertness which is required. Then prolactin levels fall with age in both men and women. Older men and postmenopausal women have lower mean serum prolactin levels and lower prolactin pulse frequency than do the premenopausal women and younger men, suggesting that a stimulatory effect of estrogen on both parameters is going away and waning down with the age. So you see the estrogen balance that I explained earlier, the how it stimulates the prolactin release. This is again important in pregnancy when a lot of estrogen is produced and that stimulates prolactin release from the pituitary. Now, what is the function of prolactin? Prolactin is essential for human species survival because it is required for milk production during pregnancy and the whole process of lactation. But there are additional functions like reproductive function, which is affected by prolactin, metabolic effects, memory development, melanin synthesis, and parental behavior. A lot of these functions are under, several biochemical and genetic research. And let's see what the future will come up with, further functioning of or actions of prolactin in our health system and health concerns. So I'm going to step by step define the various functioning of the prolactin, especially the mammary gland development. Prolactin is not essential for the pubertal memory development. Okay, at puberty, a surge of estrogen will lead the process of memory development. At the time of puberty, prolactin is not required, but progesterone, possibly in association with growth hormone and prolactin, then causes the formation of the lobular decorations along the ducts, which are the precursors to the glands, the mature forms of the mammary gland. Then the process of lactation. Active lactation is due in part to attenuation of the progesterone and estrogen and elevation of prolactin levels after delivery. In the absence of suckling, prolactin concentration, which rise throughout the gestation, returns to normal by 7 days after delivery. Prolactin is essential for milk production. The milk yield does not correlate the serum level. So you don't know if the lady has is breastfeeding. It is not necessary that she may have high has high level of prolactin levels at the same time. Lactational amenorrhea. This results in secondary infertility. A natural form of contraception depends on the frequency and duration of breastfeeding. Resumption of anovulatory menses occurs within 28 weeks after delivery. And first ovulation occurs at a mean of 34 weeks due to a persistently abnormal LH pulsatile secretion. So here comes the role of prolactin. Uh, you can understand that 4 months are required, for normal menstrual cycle to resume. And not only that, it should be an ovulatory. I mean, the ovulation should actually take place in that menstrual cycle, and that can take further long after, the delivery or the breastfeeding has been stopped. Now, coming to the reproductive function. Now, in mice, the disrupted prolactin receptor expression, both ovulation and the number of primary follicles are reduced. These findings underscore the luteotropic function of the prolactin. Hyperprolactinemia causes suppressed gonadal function, which includes short luteal phase, reduced central FSH and LH levels due to inhibition of the GnRH release, decreased granulosa cells, decreased estradiol levels, amenorrhea, and then ovarian dysfunction. But in human male subjects with hyperprolactinemia, LH and FSH pulsatility is attenuated, and testosterone levels are suppressed, and sperm counts and motility are low. So as far as the reproductive function is concerned in humans, it is actually going towards the negative side, that high prolactin would decrease the reproductive function of the human race. But in mice, and that has been, also seen and studied in mice, the exact mechanism which is taking place, especially in females, that the ovulation, the number of primary follicles are actually reduced. Now I will discuss a bit about the prolactin assays, because now gradually I'm going towards, the clinical scenarios, clinical practice, a more practical aspect of prolactin. This was the background. This was more about the physiology. We have to understand the background, otherwise we won't be able to, implicate that background, that basic physiology of prolactin to our clinical scenarios. Now, understanding prolactin assays is very important, and most important is the hook effect that takes place. Prolactin radioimmunoassay is highly specific and clearly distinguishes prolactin from growth hormone, because I told you earlier that they belong to the same class of the peptides, and because of their homologous structures, can influence each other detection during the laboratory assays. Immunoradiometric assay, that is the IRMA, and chemiluminescent prolactin assay has improved assay efficiency and turnaround time, reproducibility, and sensitivity. And with the help of this, it has become more easier for to clearly distinguish the detect the prolactin level and distinguish from the other glycoprotein hormones. Extremely high prolactin concentrations may saturate the ability of these assays to detect the correct level, reporting falsely low value because of single dilution technique commonly which is used. This is called hook effect. Now, if the prolactin is released in a very high amount, it cannot be detected by all the detecting the detectors of that assay. As a result, when you wash out the liquid phase, the remaining concentration of the protein is not detected by the sensor. This is called hook effect. And then that is the reason we have to sometime keep on diluting to up to 100 times to get the exact and correct value of prolactin level. This results in misdiagnosis of prolactin secreting macroadenomas as clinically non-functioning adenomas, with normal prolactin levels being reported in about 5% of the patients. So this is a false low, because there is a large adenoma, so there should be a large amount of prolactin that it should release, but that's not happening, and that is resulting in a misdiagnosis of macroadenoma, rather than the diagnosis is being interpreted as non-functioning adenoma. So the solution, as I told you, that serum samples should be subjected to dilution of at least 1:100 before assays. You can always ask this from your local laboratories, and current laboratories in my city are doing that. The only concern is that you should make them and understand that what are you trying to say, and you have to communicate with them. So this is a picture of the explanation of yes. So there you can understand the antigen is the prolactin hormone, okay, and this is the capture antibody. These black shadows, and this is the signal antibody, because it has a signal dot signal with that. And when this signal antibody combines with the antigen, it becomes a sandwich. So this is a very high prolactin concentration in this bottle, in this jar, and when this liquid phase is discarded, most of the antigen is lost, and the only detection is this point, this single signal antibody which is being detected. So you can understand all this is not detected. This whole portion is not detected. So this will give you a falsely low concentration of the prolactin hormone. Now let's start the topic of hyperprolactinemia. There are three main causes: physiological, pathological, and drug-induced. Physiological causes include pregnancy, lactation, stress, sleep, coitus, and exercise. And I'm going to discuss a bit about important physiological causes. Number one is pregnancy. During pregnancy, normal pituitary gland increase in size by 2 to 3 folds. And this is the result of marked increase in the number of prolactin producing cells and a relative decrease in other hormone secreting cells. And this is going on under the influence of estrogen, remember. So the serum prolactin concentration can rise to a mean of 207 microgram per liter during pregnancy. So this is the units are also very important. Make sure you are looking into the units correctly. This is microgram per liter, or it can be nanogram per ml. One and the same thing. They are same things. Okay. Only if you translate them into a nanomole per liter concentration, that is the SI units, then the figure will go in thousands. Idiopathic hyperprolactinemia. This is a condition in which there is an elevated circulating prolactin level in patients in whom no cause is identified and is considered to be idiopathic. And these cases are relatively resistant to dopamine therapy. Mean serum prolactin level in patients with idiopathic hyperprolactinemia is usually less than 100, so they're not very high. You may get a normal MRI in such condition. You may not get a correct cause, but the patient would be symptomatic with a high prolactin level, and you have to treat these patients. But as this evidence shows that they may be relatively resistant. Then there is a condition which is called macroprolactinemia. Remember, I told you about the big prolactin earlier. This is the one. And there are two causes of hyperprolactinemia due to decreased clearance of prolactin. One is the chronic renal failure, and the other is the macroprolactin. So the macroprolactinemia reflects these larger circulating prolactin molecules, which exhibit markedly reduced bioactivity and represents 85% or more of the total prolactin. So they're not, they're not bothering you, but they're giving you a large value, a large number that, oh, the prolactin is very high. But they are actually not biologically very active because they are big. Few clinical abnormalities usually associated with hyperprolactinemia, like the sexual dysfunction, the galactorrhea, the osteoporosis, can be, possible in cases with macroprolactinemia. So you have to be very careful. How do you screen this condition? This is a condition which can be screened by polyethylene glycol precipitation of the serum samples, or the gel filtration chromatography, which is the gold standard method of detecting macroprolactin levels. Unfortunately, we don't have this facility in our country. There is no polypack precipitation. There is no gel filtration chromatography. So detecting macroprolactin levels in our setup is not possible. Now, coming to the pathological conditions of hyperprolactinemia, as you can see, there is hypothalamic pituitary stalk damage, which include tumors, granulomas, Rothke cysts, radiation, and trauma to the pituitary stalk, or cellular surgery in head trauma. Then pathology related to the pituitary gland itself, which can be, various pituitary adenomas like prolactinoma itself. Then acromegaly, because it is very closely linked with the molecular structure. And also sometimes it co-secretes prolactin hormone in that somatotroph and the lactotroph both are combined and they secrete both hormones. Then non-functioning pituitary adenoma can be so large and compressive to, block the dopamine inhibition to the pituitary gland. As a result, prolactin is released in large amount. Then it can be idiopathic, plurihormonal adenoma, as I've told you, the co-secreting condition, lymphocytic hypophysitis or paracellular mass, and macroprolactinemia, as I told you. Then there are systemic disorders like chronic renal failure, cirrhosis, cranial irradiation, chest wall injury, or any type of pathology, and so on. So a little bit about the discussion of few of them. Prolactinomas, obviously, and pituitary or cellular tumors, they inhibit dopamine because of pressure on the pituitary stalk or interruption of the vascular connection between the pituitary and hypothalamus. As a result, the dopamine, the inhibitory effect is gone. Prolactinomas can manifest with any level of prolactin elevation, but when the serum prolactin level is less than 100, this is usually due to either a microprolactinoma or a non-functioning macroadenoma, which is compressing the stalk. And when the serum level is more than 200, this is almost diagnostic of a macroadenoma, that is macroprolactinoma. So remember these cutoffs, okay? This would be the main takeaway of today's talk. And anything less than 100 should, make you think about checking for the secondary causes. Ruling that out, then you can step on to check for MRI. But anything above 200 goes straight for MRI. Obviously, you have to look for other causes as well. I'll discuss now. Oops, sorry. Okay. So up to 20% of patients with hypothyroidism also have elevated prolactin levels, but the level does not go very high. Treatment of hypothyroidism with thyroid hormone normalizes serum prolactin. So you have to look for secondary causes, I told you. Instead of labeling the case of as a prolactinoma, you first have to look for secondary causes. So hypothyroidism is one of them. And once you've detected hypothyroidism, the approach is that treat that first and recheck prolactin. And if still high, then you can proceed towards pituitary-based prolactin source. Prolactin is moderately elevated, that is somewhere between somewhere around 28 microgram per liter in patients with chronic renal failure and in those being treated with dialysis. Largely a result of an increase in little prolactin due to decreased GFR or the presence of macroprolactin that takes place in case of CRF, that is the reason that prolactin would be high. In men who are on dialysis, there can be a problem with sexual dysfunction if they have hyperprolactinemia. Now, there are two emerging causes. One of them is familial idiopathic hyperprolactinemia. This is a germline mutation of the prolactin receptor gene with loss of function mutation. As a result, there is a lot of high prolactin in the blood, and that prolactin is not working on that short feedback loop that I explained you earlier. The feedback loop, the ultra short feedback loop through which prolactin is inhibiting its own release. That the receptors on the pituitary are mutated, and as a result, the short feedback loop is not working. Then there is a condition called ectopic prolactin production. This is due to large extrapituitary malignant tumors, and the patient would have a normal pituitary MRI, and you have to exclude the secondary causes. And then the pituitary level would be really high, like more than 200 in such cases, and the patient would be symptomatic. So there was a case when I was going through the literature, a young female had presented with galactorrhea and amenorrhea, and she had a high prolactin level. And then the secondary causes were evaluated, no cause was being found, even the pituitary MRI was normal. Then she started having abdominal pain, and somehow she underwent a CT scan of the abdomen and was found to have a large epithelial cell tumor in that abdomen, which was, you can say this was a epithelioid tumor. So that tumor was, then secreting this large prolactin. And it was confirmed through histopathology, through the staining of that tumor with prolactin hormone. It was confirmed through that. So there is a condition of ectopic prolactin production. We have to keep our eyes and mind open to understand and to detect these cases. Then coming to the pharmacological causes, there are various pharmacological drugs which can release the, increase the prolactin hormone. Dopamine receptor blockers, tricyclic antidepressants, then catecholamine depleters like reserpine. These are not really, very commonly used, but some drugs are very commonly used like antihypertensive labetalol and verapamil. Then antihistamines and even the proton pump inhibitors. Obviously the oral contraceptives, because they will have estrogen which will stimulate the prolactin release. Then there are anticonvulsants and these miscellaneous type of drugs, and then opioids, as I told you earlier, and antidepressants. So you have to be watchful and take a detailed drug history from the patient to understand the cause of hyperprolactinemia. So a little bit about the pharmacological causes. Drug-induced increase in prolactins are usually less than 150. It can be more than 200 and 400 as well, but they are selective drugs. Unless patient exhibits sexual dysfunction-related osteoporosis or troublesome galactorrhea, no treatment of drug-induced hyperprolactinemia is recommended. Exclude the non-drug related causes as well in certain conditions, because sometimes patient may be on those drugs which are responsible for hyperprolactinemia, but they're not always the cause. It is not necessary that those drugs are the cause of hyperprolactinemia in a particular patient. So if the levels are very high, think about checking for an MRI or checking for other causes. Prolactinoma, other cellular lesions, hypothyroidism, or renal failure should be considered in such cases, as I told you. And then you can, assess for a temporary drug withdrawal. And if the prolactin levels do not normalize, then go for pituitary MRI. Switching to olanzapine or aripiprazole when the drugs are antipsychotics may be attempted, but in close liaison with the psychiatrist. Otherwise, patient would be in great trouble. Now, let's begin with the clinical features of hyperprolactinemia. Galactorrhea, reproductive function, they are the dysfunction, are the hallmarks of non-physiological hyperprolactinemia, okay? So anyway, a patient presents with a reproductive dysfunction and galactorrhea, think about hyperprolactinemia. Women present with galactorrhea associated with a range of menstrual irregularity, including oligomenorrhea, amenorrhea, there can be menorrhagia, and so on. Patients with postpartum amenorrhea, hyperprolactinemia, and galactorrhea have also been found to harbor prolactinomas. So don't, just block your mind thinking that this is lactational and this is postpartum and it will take time to get resolved, because sometimes levels can be high enough to, to highlight the importance of checking for prolactinomas. Galactoria also occurs infrequently in men, and if it occurs in men, then understand that patient, the male patient is harboring a big tumor and is releasing a lot of prolactin, so that the patient is starting complaining of galactoria, which is not easy to manifest in men as such. Men can present with symptoms of hypogonadism and tumor mass effects as well. So for galactoria, inappropriate nipple secretion of milk-like substances may persist after childbirth or discontinuation of nursing for as long as 6 months. But beyond that time, then other causes of galacturia should be investigated. In 2/3 of patients, postpartum galacturia persists despite the resumption of menses, and this probably does not represent a pathologic entity. So just keep on, on the follow-up and check for the levels, check for the other pathologies, and maybe that resolves automatically with the passage of time. Normal prolactin levels may still permit milk production, and the treatment of such patients with dopamine agonists alleviates galacturia. So this is the condition which is called idiopathic galacturia, and sometimes we have to treat these patients with dopamine agonist therapy in order to relieve the symptoms. Coming to the menstrual irregularity, as I told you, there is a range of menstrual irregularity which can happen: oligomenorrhea, menorrhagia, primary, secondary amenorrhea, delayed menarche, and even if the menstrual cycle is normal, there would be a short luteal phase which can affect the fertility of the patient. Then elevated prolactin has a short loop feedback effect on gonadotropin pulsatility that presumably inhibits gonadotropin releasing hormone as well as LH pulse frequency and amplitude. High prolactin also directly inhibits ovarian and testicular function. Patients may also report changes in libido and vaginal dryness. Sexual dysfunction in men manifests as loss or decrease in libido, impotence, premature ejaculation, or intracoital erection loss, oligospermia, or azoospermia. Then osteopenia, bone density is also affected by hyperprolactinemia, because hyperprolactinemia induces sex steroid deficiency in both men and women. As a result, the protective effect of these steroids is lost. Restoration of menses following therapy results in an increase in bone density. However, this bone density may not always return to normal. Then coming to the tumor mass effects. Prolactinomas may manifest with signs and symptoms resulting from the tumor size or invasiveness. In case of microadenomas, it can be entirely asymptomatic. Okay, sometimes it may not be always detected. And microadenomas can be as small as 2 to 3 millimeter, to the large ones like up to 10 millimeter, but still less than 1 centimeter in size. They can be invasive as well. Don't underestimate the microadenoma size, because they can be invasive despite their small size. And sometimes these microadenomas may not be actually detectable on MRI. So remember, I explained a condition earlier that is called idiopathic hyperprolactinemia, because that is the condition when you check for MRI and the MRI is normal, and you say there is no pituitary adenoma, but there are sometimes small pituitary adenomas which are not detected on MRI, but they are the ones which are responsible for prolactin release. Macroadenomas, they can be non-invasive or diffuse tumors approximately 1 centimeter or more in size, and sometimes they can be huge tumors that may impinge on the parasalar structures like optic chiasm, cavernous sinus, and sphenoid sinus, and can actually result in CS aprinorrhea. So the compressive effects on the visual structures can result in loss of vision. There can be bitemporal hemianopia, superior bitemporal defects, and decreased visual acuity. So there can be a lot of variation. We all often do the clinical confrontation testing in our OPDs and clinics to see if there is a bitemporal defect, but don't estimate there can be other forms of visual losses. So get a perimetry done. Then there can be headaches, which are common with large tumors. Seizures can happen, hydrocephalus can occur, cranial nerve palsies, and unilateral exophthalmos. They all can occur, but they are very rare conditions. And invasion of the cavernous sinus can also take place, and that can result, in cranial nerve palsies more rather than the effect of the tumor itself. Then there is a condition that when a sudden insult takes place in that large macroadenoma, which can result in pituitary apoplexy. And this is more common cause of all those palsies and maybe a presenting symptom as well. So if a patient presents with a cranial nerve palsy, just raise your ears and send an alarm that this is a neurosurgical emergency, and patient has to be dealt with a neurosurgeon as soon as possible. Prolactinomas can also be found inadvertently on an MRI or CT scan performed for another purpose, and in that case, you often think about that is it a pituitary incidentaloma or is it a prolactinoma? Then you go on checking for the anterior pituitary functions. Now we will start the topic of prolactin secreting adenomas. Prolactin secreting adenomas, they are most frequently encountered secretory pituitary tumor. So when we talk about the pituitary tumor in general and pituitary adenomas in general, the commonest type of adenoma or pituitary adenoma, pituitary tumor is a prolactin secreting pituitary adenoma. And the annual incidence is approximately 30 per 100,000 persons, slight with variation depending on maybe ethnicity or geography. And then female to male ratio, it depends. If there is a microprolactinoma, then it is 20:1, whereas macroprolactinoma can occur on an equal ratio basis in both gender. More than 75% of all female pituitary adenomas are prolactin secreting adenomas. And if a man is affected by prolactin secreting adenoma, then he tends to harbor larger tumors. Because you see, the small microadenomas in female would affect their menstrual cycle, and missing a menstrual cycle a month would bring a female patient to the clinical attention, to the healthcare attention. But in case of males, it doesn't affect, they don't have these menstrual cycles. So until unless the prolactin is so high to affect their libido, they won't be attending any clinician as such. And their prolactin and microadenoma, their adenoma would tend to increase in size with the passage of time. So a little bit about micro versus macroadenoma. What are their clinical and characteristical differences? Microprolactinomas may disappear after discontinuation of dopamine agonist therapy, but sometimes 7 to 14% of cases they may continue to grow. So don't think that if you treat or cure a case of microprolactinoma with dopamine agonist therapy, then the patient is cured for life, and you don't have to follow the patient is gone. So there is a risk of recurrence. Macroprolactinomas, they grow rapidly. The tumor size often correlates with the serum prolactin levels, and they manifest with compressive symptoms. For prolactin levels, so for the prolactin level which is greater than 200 nanogram per ml or microgram per liter, remember the unit difference. Sometimes check for the drug risperidone. Risperidone has been shown to have a to induce to stimulate prolactin levels, to cause a very high levels of prolactin. And often when it is more than 200, and if the patient is taking risperidone, just be cautious in interpreting whether it is drug induced or if there is a macroprolactin, macroadenoma there in the pituitary. So again, you have to consult the psychiatrist here, understand if the drug can be changed, and if after changing the prolactin level comes down, then it was drug induced. Otherwise, you have to proceed towards MRI. However, levels greater than 500 nanogram per ml are exclusively observed in patients with prolactinomas, and these are macroprolactinomas. Sometimes there can be giant prolactinomas. So there is a condition which is called giant prolactinomas. These are the tumors which are larger than 4 centimeter in diameter by definition. And the serum prolactin level is often very high and are higher than 1000 nanogram per ml. And they occur more commonly in men. So they are difficult to treat. Again, the treatment strategy is the same, which I'm going to discuss, but they may have complexities, so you have to be watchful to them. Then prolactinomas are also the most slow-growing tumors as well. They may arise sporadically, they can occur singly and are monoclonal, but sometimes more than one prolactinoma may be present in the single pituitary gland. So one can be on the right lobe and the other can be on the left lobe. They are the most commonly pituitary adenomas associated with the MEN1 syndrome, MEN1 syndrome. And then there is a condition which is called, which is familial prolactinomas, but it has no other features of MEN1 syndrome. So if you take a family history, they can tell you that it was a prolactinoma, but you will not find other features of MEN1. Now, what is the pathology and pathogenesis of these prolactinomas? Immunostaining for the prolactin confirms the diagnosis of prolactinoma, but this is not available here in our setup in our country, okay? So we have to rely on the prolactin levels anyway, but this is the one which is diagnostic. These tumors, they have a pseudocapsule, and this is composed of a compressed adenohypophyseal cells surrounding adenohypophyseal cell, which were which were compressed, and there is reticulin fiber network, and the combination of these two structures make a pseudocapsule. So the prolactinomas can be benign, intermediate, and malignant. As you can see, benign are mostly, they comprises more than 99% of the prolactinomas. They are often sharply demarcated without evidence of invasion. About half invade local structures, but even invasive tumors that do not metastasize, they are considered as benign. Even if they are invading, they are not considered as metastatic. Intermediate ones are the ones which have invasion into the adjacent dura, bone, and the venous structure, the cavernous sinuses. But again, they are not considered as metastatic. But since they are invading a lot of structures and can be, difficult to treat or manage, then they are considered as intermediate variety. For malignant prolactinoma, they are extremely rare. And for a prolactinoma to be considered malignant, a distant extracranial metastasis needs to be demonstrated extracranial, remember, not within the brain itself. Now, a little bit about a correlation of the prolactin levels and the possible etiology. From the level of prolactin level, the patient from the figure, from the number that the patient brings to you, you can have an idea of what can be the underlying pathology. As you can see here, this is a very famous figure, as most of the fellows who are listening to me must be aware of this figure. And you can see that the levels are really in thousands in case of macroadenoma, whereas in micro it is somewhere in hardly beyond 200, right? Then there are other causes of hyperprolactinemia, like which can be pituitary tumor or Mast stalk effect. They are also not above 200, mostly less than 200. However, in pregnancy, the levels can go up to nearly thousands, because pregnancy is a condition of high estrogen level. During stress, the levels are less than 100 and mostly around 50 to 80 or so, and not high. And in such condition, you should always, recheck the serum prolactin level after, asking the patient to avoid these stressful conditions, which can be a tourniquet when the patient's blood sample is drawn. Simple tourniquet applied during the blood sampling is a matter of stress. So you can, in fact, this practice is being done in UK, and in this way, a lot of misinterpretation of hyperprolactin levels are managed. And then there are drugs which have similar effect of microadenomas, can have similar range. So you have to be cautious and careful in interpreting whether these drugs are the cause of hyperprolactinemia, or there is really a micro or macroadenoma underlying there. Now I will talk about how to evaluate a case of hyperprolactinemia. So evaluation is through a clinical approach. If an initial serum prolactin concentration is only slightly elevated, that means it is less than 40, less than 50, somewhere between 21 to 40. Usually the upper limit of the laboratories are usually 20, 23, and so on. The test should be repeated at least once again. And if the serum prolactin is elevated on the second sample, then you would say this is a hyperprolactinemia, and then you will determine the cause. So most patients of the with hyperprolactinemia, they may have lactotroph adenoma. So keep your suspicion high and evaluate accordingly. The evaluation also is aimed to exclude the pharmacological or extra pituitary causes of hyperprolactinemia, number one. And then number two, to check, okay, there are no secondary causes, no extra pituitary causes, then you will go for an MRI or neuroradiological evaluation. So take a good history, rule out pregnancy, check medications, check for compressive symptoms, hypothyroidism, renal failure, two most important and common clinical conditions to be checked in history. Then do a physical examination, check for the visual field defects and any chest wall injury, signs, symptoms of hypothyroidism or hypogonadism, and then move on to the laboratory test. So studies should be performed to test for hypothyroidism and renal insufficiency. Always check these conditions when you are interpreting a case of hyperprolactinemia. Prolactin is elevated in up to 50% of patients with acromegaly as well. So patients in the early stages of acromegaly may have few obvious signs of growth hormone excess and can actually present with hyperprolactinemia. So be careful. In that condition, you may have to check IGF-1 levels as well, because human growth hormone molecule exhibits lactogenic properties similar to prolactin, and the sign and symptoms of prolactinoma may be mimicked by a purely growth hormone secreting tumor. So be careful. You may miss a case of acromegaly otherwise. Elevated prolactin levels are occasionally encountered in patients with TSH secreting tumors. However, this is very, very rare. And there are no stimulatory or suppressive endocrine disorders that can distinguish between the various causes of hyperprolactinemia. In fact, there are no recommended pituitary dynamic function testing to assess whether there is hyperprolactinemia or not. As I told you earlier, you have to take 2 different samples. You have to recheck always to see if there is a hyperprolactinemia or not. Then coming to the imaging, MRI of the head should be performed in a patient with hyperprolactinemia who has more than 200 nanogram per ml to look for a mass lesion in the hypothalamic pituitary region. So in case of hyperprolactinemia, you don't only have to write MRI pituitary protocol, you should write MRI of the head, because there can be a mass or a structure lesion which is above pituitary or sella region and still affecting the pituitary stalk and the dopamine axis, and then it can have hyperprolactinemia. The hypersecretion of other pituitary hormones would be found in case there is a pituitary adenoma, and hyposecretion of one or more pituitary hormones may be found if there is no pituitary adenoma but there is a mass lesion in the area of the sella. So check other pituitary hormones. If other hormones are raised, the likely possibility is pituitary related hyperprolactinemia. Otherwise, there can be other mass lesion, like there can be a meningioma, there can be a dermoid cyst, there can be other lesions which are related to the SLR area. MRI shows normal hypopituitary. When the MRI shows a normal hypothalamic pituitary region and no obvious causes are found, then there can be 2 conditions. Number 1 is the idiopathic hyperprolactinemia, in which the microadenoma is too small to be seen on the imaging. Other condition is familial hyperprolactinemia, where there is a prolactin receptor gene mutation, and I've explained these 2 conditions earlier. Now, when do you order for MRI in a drug-induced hyperprolactinemia? Again, I've told you earlier then that there can be condition that it depends on the degree of elevation of the prolactin, and most drugs will cause an elevation over around 100, but some certain antipsychotics like risperidone can cause the levels up to 400. And here you have to be careful. You have to stop the drug in line with the psychiatrist and see if the levels come down. If it doesn't, then you have to go for MRI. So if the order an MRI if the prolactin concentration is greater than 100 in patients who are taking a drug which is known to elevate the prolactin concentration. But in case if the patient is taking risperidone, you can say, okay, the 100 level can be because of the risperidone. But if the level is really above 400, then order an MRI. This is a nutshell of, I've just explained how do you diagnose a case of hyperprolactinemia, what can be the approach. If you see there is a clinical picture with hyperprolactinemia, the signs and symptoms are there, you confirm there is a prolactin, which is a cause, check for the level. If level is less than 200, investigate the secondary causes. If yes, then treat them. If no, then consider checking MRI. In case if in the MRI no tumor is found, then the 2 conditions are idiopathic and familial hyperprolactinemia. And if on MRI you get a microadenoma, then that is microprolactinoma. If the level is more than 200, you go straight for MRI because a macroprolactinoma would be there. Now I'm coming to the last section of my talk, that is management of hyperprolactinemia. Now, what are the conditions or indications for treatment? There are 2 principal reasons you have to treat hyperprolactinemia. Number 1 is existing or impending neurological symptoms due to the large size of the lactotroph adenoma. And number 2 is the hypogonadism or other symptoms due to hyperprolactinemia, such as galacturia, because the patient is symptomatic and needs treatment. Treatment is 3-pronged approach: medical treatment, surgical treatment, and radiotherapy. And as you can see the sequence, this is the sequence how a case of prolactin adenoma has to be treated. You have to go for medical treatment because that is the first line therapy. Treatment goal is normalization of prolactin levels and associated signs and symptoms, and complete tumor removal or shrinkage with reversal of tumor mass effects. So there are two main goals. Prolactin levels should come to normal. Second, the tumor should also shrink down. So these will be the two parameters that you will follow and monitor in a case of hyperprolactinemia related to prolactin secreting adenoma. Medical management of prolactinoma is with dopamine agonist drugs, and it is widely known and recommended. The treatment of choice is cabergoline and bromocriptine. There are other ergot alkaloids which have been used in the past, but now mostly the recommendations or guidelines focus on the use of these two main drugs, and even out of these two, the first line treatment option is cabergoline. Prolactinomas, they are after treatment, they are either completely or substantially. Prolactinomas which are completely or substantially resistant to medications, they are infrequently encountered, and most resistant patients also have partial resistance because tumor would shrink down but may not, go away. And the prolactin levels also get lowered down, but they may not normalize. So it depends on the efficacy of these drugs, which I'm going to discuss. So cabergoline is the first-line therapeutic choice for most patients with even giant prolactinomas, unless there is a pregnancy which is desired, and because there is little data about the safety. However, there is no adverse effect so far in literature, so people often continue using cabergoline even during pregnancy. Cabergoline has a longer duration of action than bromocriptine and is usually administered once or twice weekly. Tumor size reduction and stabilization is achieved in 80%, and normalization of prolactin levels and remission occurs in 75 to 95%. For the fellows, I think you have to remember these figures because they can be asked in your exams. More effective, cabergoline is more effective than bromocriptine in restoring the ovulatory cycles and fertility. It is better tolerated than bromocriptine and cause few similar side effects. Cabergoline also may result in dramatic improvement of prolactinoma-associated headaches. The long half-life of cabergoline is because of its high affinity to the D2 receptors. Bromocriptine is a synthetic ergot alkaloid dopamine agonist. It normalizes the prolactin and restores abnormal menstrual function in 80 to 90%. So normalization part, which is the first goal, and that is 80 to 90%, and the improvement in the visual field abnormalities occurs in 90%. Then shrinking the prolactinoma is again achieved in 80%. So the two goals, the tumor size should reduce as well. The drug withdrawal can result in rapid tumor expansion. So you see the after you withdraw the drug, there's a high chance of recurrence. That's why it is considered to be less effective than cabergoline. Complete or partial resistance to the effects of bromocriptine, even at high doses, have been reported. And in such cases, you may either, you go for higher doses of the bromocriptine or change from bromocriptine to cabergoline. Resistance to dopamine agonists may reflect the reduced D2 receptor binding site or receptor gene polymorphism where bromocriptine is not able to act. This is an example of a lactotrop which has been treated with cabergoline, and you can see how the tumor, as shown on the figure A, has actually got vanished in figure C. So this is very dramatic and very quick, and you can achieve this in, I think, rough around 48 to 72 hours. The quick response we get is the visual acuity or visual field effect becomes normal. Patient symptoms may improve, especially with respect to headache and galacturia. Now, the adverse effects of dopamine agonists. Nausea can occur, and nasal stuffiness, depression, digital vasospasm because of the alkaloid effects, ergot alkaloid effects. Postural hypotension is also due to the same reason. If the patient has an underlying psychosis, that can be exacerbated. So a careful history of psychotic symptoms should be, taken from the patient, especially when the patient has been started on this drug and suddenly started developing, abnormal psychotic behaviors. CSF rhinorrhea in up to 6.1% of patients with macro and giant tumors, macroadenomas and giant tumors can occur because these tumors, they function as a cork over the cellular bone. And as soon as they shrink down, the cork is removed, the CSF rhinorrhea start taking place. And the issue is that passage becomes a free entry for bacteria, and there is a risk of meningitis. Now, there are rare side effects like hepatic dysfunction and cardiac arrhythmias. Then retroperitoneal fibrosis, pleural effusion and thickening, and restrictive mitral regurgitation with high doses of bromocriptine can take place. So, in concern with this fact that patient can develop a valvular heart disease, the British Society of Echocardiography, Heart Valve Society, and Society for Endocrinology in 2019, they come up with this position statement that a standard echocardiogram should be performed before patient starts dopamine agonist therapy for hyperprolactinemia. Repeat echo should be performed at every 5 years after starting the gabapentin in patients taking a total weekly dose less than or equal to 2 milligram. However, if the patient is taking more than a total weekly dose of 2 milligram, then echo should be performed annually. So this is a very important recommendation which we need to, start practicing in our patients. And once we are confused that if the patient has an underlying valvular heart disease already, then you may consult the cardiologist that how bad it is, because the patient would need a dopamine agonist therapy. So a close liaison with cardiologist would be required. Now, the question is when to stop the dopamine agonist treatment. This is mostly in concern with the micro adenomas, that is microprolactinoma, because in the case of macroprolactinoma, the treatment is usually cumbersome and takes a lot of time and it's quite long. I wouldn't say lifelong because there are cases which can be cured, but for microprolactinoma, it is often assumed that it should go away. So a good candidate for withdrawal would be the one who is treated for 2 years with gabapentin and has normal prolactin level on a very low maintenance dose of gabapentin, and there is no tumor like idiopathic hyperprolactinemia, or if there is a tumor, the reduction is more than 50% achieved on an MRI. Then the second line treatment is surgery. The success rate of pituitary surgery correlates inversely with the tumor size and serum prolactin concentration, unfortunately. So in case of hyperprolactinemia, there is a high possibility of surgical cure rate. Recurrence is also relatively high, but because you see, they can always recur. The recurrence rate is 17%. Macroprolactinoma, complete resection of large invasive tumor, is difficult to achieve in such cases. And even the post-operative serum prolactin does not normalize and is only achieved in 32% of cases with a 19% recurrence rate. And in all such cases, the experience of the surgeon in handling such cases of paramount importance. Not every neurosurgeon can deal with the pituitary surgeries. Now, what are the indications of surgery? Patients with prolactinoma that are resistant to dopamine agonist therapy. Number two, the patient presenting with pituitary apoplexy or CSF rhinorrhea. This is like a neurosurgical emergency. Prophylactic transfemoral surgery can be performed in women who have prolactinoma and are large enough to potentially threaten the vision during pregnancy and they are planning pregnancy. So, as a plan to, get rid of the condition before planning pregnancy, you can go ask for transfemoral surgery. Then there is a subset of patients who cannot tolerate the medical treatment and they prefer going for surgery instead of medications. A little bit about the radiation therapy. Linear accelerator radiotherapy or gamma knife radiotherapy is being now performed for macroadenomas or resistant kind of prolactinomas. If this is effective in controlling or reducing the size of prolactinoma, however, the therapy takes many years to achieve maximal effect. And meanwhile, you may have to put the patient on medications. The side effect of most concern is hypopituitarism, and that results in any kind of radiation to the pituitary area. However, the radiation therapy is useful in the control of tumor growth, but it is not as effective as dopamine agonist therapy. So that is the reason even in large macroadenomas and giant prolactinomas, you should go with medical therapies as a first line. Other option is chemotherapy. This has become an area of growing interest, and they can be used for treating aggressive and giant prolactin secreting tumors unresponsive to other therapies. Temozolomide is one of them. It is an alkylating compound which readily crosses the blood-brain barrier and controls the tumor growth. The response to temozolomide may be predicted by low tumor staining for O-methylguanine DNA methyltransferase, but nothing of the sort happens here. So it is just of theoretical, concern and interest. Now, the special topic that I mentioned, pregnancy, because you are dealing with female of reproductive age group and they're often coming to you with infertility, so you have to manage them accordingly. Normal pituitary enlarges during pregnancy, and prolactinomas may also increase in size during pregnancy. So if there is a pregnancy-associated tumor enlargement, this is determined by the development of abnormal visual field. So the only thing that you will ask your female patient when she becomes pregnant to keep, a watch on her visual field. Check her vision, be watchful, and anything bad happens, come to the clinic, come to the medical attention. There is a possibility of 1.4% enlargement with microadenomas, whereas there is a 16% of tumor enlargement risk with macroadenomas. Dopamine agonist therapy can be used during pregnancy to prevent tumor growth. It seems prudent to reduce the fetal exposure to medication if possible. There has been no, reported side effects or teratogenic effects of concern, but it is better to avoid such medications during pregnancy. So this is how you plan a case of prolactinoma in patients who are planning pregnancy. If there is a microadenoma, discontinue the dopamine agonist therapy when the pregnancy test is positive. Do periodic visual field examination during pregnancy, maybe monthly or 3 monthly. And after postpartum, you can check for MRI after 6 weeks. Whereas for macroadenoma, consider doing surgery before getting pregnant. And then ensure that bromocriptine sensitivity is there with the pregnant woman. Patient is responsive to bromocriptine, for example, if it is required. Monitor visual fields and frequently and expectantly, and administer bromocriptine if vision becomes compromised. Or you can continue bromocriptine throughout pregnancy if the tumor had previously affected vision, so you cannot take the risk of getting your vision affected. And if in case it does become affected, then consider high dose steroids or plan the patient for surgery even during pregnancy to save the vision or save adenoma for getting a hemorrhage. And again, do a postpartum MRI after 6 weeks. I think this is a brief or flow chart which shows how you go about with micro and macroadenoma. You have to start the patient on dopamine agonist therapy, titrate the dose, see the response, and so on. Monitor the prolactin level, repeat the MRI annually. I won't go into much detail because I have already explained. And if, for example, it is a case of a macroadenoma which is not responding to medication, then you can go for surgery on one end, or you can either switch the medication, see if there is a dopamine resistance is the issue. Otherwise, you can go for radiotherapy and so on. So in the end, I have a case for review for you. This is a 32-year-old man who presents with a 3-week history of peripheral vision loss and a 6-month history of fatigue and low libido. He reports no headache, diplopia, nipple tenderness or discharge, increase in hand or shoe size or weight change. His medical history is unremarkable and he takes no medication. He's single and has no children. So the only problem is the visual loss and a history of fatigue and low libido. On physical examination, he is normotensive, appears well, no features of acromegaly or Cushing's. Bitemporal visual field defects are present on confrontation, and his disease are 15 liters bilaterally. An examination of the genitalia is otherwise normal, muscle strength is intact. Lab results show a serum prolactin level of 45, and the range is between 423. IGF-1 is 122, TSH is 2.7, AM cortisol is 17, LH and FSH are on the low side or below the range. This is the MRI of the brain, which shows a large stellar mass compressing the optic chiasm. I hope you can see all. You all can see that. So the question is, which of the following laboratory measurements should you order next? Either serum macroprolactin, serum free T4, serum prolactin in dilution, serum testosterone, or serum alpha subunit. So this is supposed to be an interactive question, but I will explain. So you see the patient is quite symptomatic. If I go back with respect to he has a compressive effect as well as endocrine effect. Both of the issues are there. However, and he has a big mass here, big cellular mass, but this big cellular mass is not correlating with the serum prolactin level. So what will you do? You will go for serum prolactin in dilution. First, you have to confirm that is the prolactin really high or not, because there can be a hook effect, which I explained earlier. These are my references, and I'm not sure if we have time for any question. Thank you very much.